these guidelines are from the APEG consensus guidelines for use of bisphosphonate in children and adolescents. Briefly summarizing, so bisphosphonates inhibit the osteoclastic activity primarily by disrupting osteoclastogenesis. While these children will continue to have a normal bone growth, the bone remodeling is reduced. So there is an increase in trabecular bone as well as cortical width in these children. Bisphosphonates are retained in the skeleton with renal excretion seen even after 8 years of stopping therapy. The treatment has been recommended for osteoporosis, cerebral palsy, distal muscular dystrophy, fibrous dysplasia, and so many other indications that I will be subsequently talking about. So directly moving on to the recommendations in a child with primary osteoporosis with evidence of fragility fractures. So again, just a low bone mineral density will not validate starting therapy. If this is not the condition, you optimize bone health by measures as Sir said, increase protein and diet, calcium, vitamin D supplementation, weight-bearing exercises, but you don't give bisphosphonate therapy here. And if primary osteoporosis is present, then along with optimization of bone health, you consider bisphosphonate therapy. Again, zoledronic acid in the dose of 0.1 milligrams per kg per year in 2 divided doses with a maximum dose of 5 milligrams annually, and palmitonate 9 milligrams per kg per year in 4 to 6 divided doses. And again, as Sir has said, palmitonate needs to be given over 3 days every time. Zoledronic acid, one-time daycare admission can be given over 15 to 30 minutes in 100 ml. These children then need to be reviewed annually, and you reassess their height, pubertal status, repeat their DEXA, and do a height adjusted Z-score where you correct it for height, for pubertal status, and then you reassess the Z-score. So if your Z-score has gone greater than 0 in a child with primary osteoporosis, you reduce the zoledronate dose to 1/4, that is 0.025 milligrams per kg annually, and palmitonate again 3 mg per kg per year in 2 divided doses. This therapy needs to be ceased at cessation of linear growth. Between 0 and -2 SDS Z-score, consider halving the annual dose. And if your Z-score remains less than -2, then you continue the annual dose of 0.1 milligrams and 9 milligrams of palmitonate as previously described. If it's a child with secondary osteoporosis, that is low bone mineral density with evidence of fragility fracture, again, no role of just a low bone mineral density. If that is not the case, you just optimize bone health, do not give bisphosphonate. But if the child qualifies for secondary osteoporosis, you optimize bone health, treat the underlying condition because that itself will improve the bone mineral density. Pubertal induction wherever applicable, especially in children with hypogonadism, and you give similar doses of zoledronate and palmitonate, but here the therapy will be continued for 12 months, and then you reassess at 12 months to decide whether or not to continue. Wherever possible, try discontinuing bisphosphonate in children with secondary osteoporosis. However, in the presence of ongoing primary issue, ongoing bone pain, fractures, or a persisting low bone mineral density, you consider a maintenance dose of that is 1/4 the original, so 0.025 milligrams per kg annually for zoledronic acid and 3 milligrams per kg per year in 2 divided doses palmitonate. Again, this needs to stop at cessation of linear growth. If the underlying disease is ongoing, you may also consider a biannual DEXA, and depending on the worsening of DEXA, you may choose to give a top-up dose of bisphosphonate or increase them if needed. So, few other conditions that I would like to describe the role of bisphosphonate. Cerebral palsy, we know that there is reduced mobility, poor nutrition, anticonvulsants, limited sun exposure, delayed puberty, all leading to a compromised bone mineral density. There's an annual fracture rate of 5%, predominantly affecting the lower limbs. And bisphosphonates have been shown to improve the bone mineral density. However, there is limited data on how much they reduce the future risk of fractures. So in children with cerebral palsy, bisphosphonates are recommended beyond 2 years of age. Do an annual BMD wherever feasible, and treat only in the presence of low BMD with fracture. In Duchenne's muscular dystrophy, the studies are mostly observational with no RCTs. Again, you know the pathology here. There's reduced mobility, a prolonged glucocorticoid therapy, and a delayed puberty. So in these children, bisphosphonates with pubertal induction helps in improving bone mineral density. Hypercalcemia is an acute indication for which bisphosphonates may be used. So hypercalcemia that is refractory to dietary manipulation and intravenous hydration is where you will use them. The dose is 0.0125 milligrams per kg of zolendronate or 0.25 milligrams per kg of palmidronate, and you wait for 48 hours before repeating the dose. So the common side effects that are seen with bisphosphonate therapy and acute phase response, which can be in the form of fever, nausea, vomiting, or hypocalcemia. Treatment for acute phase response is that you pre-medicate them with paracetamol and anti-nausea medication. And for hypocalcemia, you ensure a normal calcium vitamin D status before initiating bisphosphonate therapy. And another option of reducing these acute side effects is giving a smaller initial dose of bisphosphonates. Other common side effects include iritis. So, if on follow-up you see a child on bisphosphonate therapy who has developed a red painful eye, get an immediate ophthalmic consultation. This is more commonly seen in secondary osteoporosis of children with rheumatological conditions. Atypical femoral fractures, as sir has already said, it is because of the bisphosphonate lines of healing and the dense and rare rarefaction lines seen on X-ray. And these are usually drug-related, may not always be considered as a pathological fracture and need for escalating therapy. Osteonecrosis of jaw, rare in children. However, a pre-therapy and a follow-up dental checkup may be a good option to prevent this risk factor. Esophagitis is common with oral bisphosphonates, so it should be avoided in children who cannot swallow the whole tablet, need to break it into pieces to swallow. Again, delayed bone healing is a plus minus thing. Some studies suggest that the callus formation is disrupted because of bisphosphonate therapy, and therefore they have recommended giving bisphosphonate after callus formation in OI. However, this is again a controversial thing. Teratogenic effects have been seen because of prolonged deposition of bisphosphonates. There have been rat studies that have shown teratogenesis in the babies of female rats who were given bisphosphonate therapy. However, there's not sufficient data to claim, and pregnancy should be avoided within 12 months of therapy. The contraindications of pregnancy, a Z-score more than +2, any acute or chronic renal failure, especially as sir has said that if your eGFR is less than 30 ml per minute, then you avoid bisphosphonates. In sclerotic conditions, so child with frequent fractures but a high BMD, you do not give bisphosphonate therapy, and in children with active rickets. Lab and assessment, again, sir is already discussed, so I will not. An important thing is doing HCG levels before every dose in postmenarchal females. BMD should be done prior to first dose because that will help you decide whether you need to halve your dose subsequently, continue the same, or make it 1/4. So just going by the fracture or vertebral fracture may not do. It is good to have baseline BMD. And when you follow up, do it on the same machine. Repeat biochemistry as relevant. So the summary is treat only those with significant fractures. There is no role of prophylactic therapy. Baseline BMD and biochemical investigations are a must. Administer zolendronate on a daycare basis so that you can watch for complications and prevent them at the earliest. Monitor and reassess need for further therapy.
There is now a lot of debate about two issues. One is about whether you would basically be giving a reactive versus a proactive strategy. So this is a 2018 guideline from APEG. So they are talking about more of a proactive strategy. So if you are somebody who has glucocorticoid induced osteoporosis, BMD is -3.5, you wait and let them have fracture and then you treat. So this is a sort of a scenario. Now things are changing, which of course is more of a fatalistic scenario. If the risk of fracture, see, why are you treating? You want to prevent fractures. So the main aim is when your risk of fracture is much higher, the pretest probability is high, you treat. That is why those new guidelines also we need to consider, in which I talked about that if your BMD is below -3 and it is declining during puberty, that itself means that there is a very high risk, so better to treat. And if you have an underlying condition below -2.5, so why have they used -2.5? Because of the adult criteria for osteoporosis is -2.5. And below that, it is declining, then with risk factor. Somebody is on steroids, the BMD Z score is -2.7. 1 year later, it became -3.2. So it may be always better to start treatment in that regards. Similarly, OI, who has a very family history, somebody who has had multiple fractures to begin with, you know the same gene is there, child comes to you, whether you wait for too many fractures, you start treatment, these all will be important to remember. So what it is trying to tell us is that with more experience, people are becoming more comfortable in using the drug. Like growth hormone, when it was started, people used to only if the growth hormone was below 1, then 3, then 5, then 7, then 10. And then anybody, so anybody who's idiopathic short stature. So as you know that this drug is reasonably safe if you use it properly, your use will be much more in that perspective. The healing part is still a sort of a debate, but most of us would not wait for a long period for fracture healing because fractures will happen in OI. It's not that then you will be always trying to delay it further from that perspective. So Vibha, you were asking something now.
Start the program along with the bisphosphonate.
Yes, so when you're talking about that is more for glucocorticoid induced osteoporosis.
One of the patients is a genetic proven OI.
OI.
So whether we should
Okay, so as discussed in OI, growth hormone may not be a very good drug. That is the main problem. So yes, so if you are able to show that there is some other, so if it's because of deformities, then we will not give growth hormone. But if there is minimal deformities, she has OI and she's very short, then we can consider growth hormone.
And the skeletal dysplasia, but no osteoporosis.
That is a situation. Yes. So I think Dr. Rajiv probably is not joined today, otherwise he would have put the question. So that is a debatable issue on that. So what we need to understand is that that's why she was talking about, Dr. Dhwani, that in the absence of pathological fractures, it may not be prudent to start. So better would be to get a BMD done and see how low the BMD is. If it's very low, and then try to look at the genotype-phenotype correlation of that particular mutation, because everybody with the same mutation will not behave similarly. So then you can make a call on that, whether this is going to fracture or not, and then treat. So if you go by the APEG guidelines, they will not recommend treatment because that's what she said, primary osteoporosis, unless you have fractures, you don't treat. That's what the guidelines would be. But better would be to get a BMD done to get a more reasonable idea.